So let's move on to Chapter 4, Part B, and we're going to talk about obstructive airways disease. So remember that increased airways resistance, either acutely, which typically you see in asthma, or chronically, as you see in chronic obstructive pulmonary disease, it tends to result in high lung volume breathing. And the reason is that breathing at high lung volume, well, that's not the reason, but one of the consequences of breathing at high lung volume is that it increases the elastic work of breathing because the compliances of both the lungs and chest wall decrease at higher lung volume, and you can readily appreciate that from taking a look at the Campbell diagram. And this is what I was trying to say. The reason is that these patients breathe at high lung volume. And again, you can see this as an example in Chapter 1, and that as lung volume increases, you tend to tether the large airways open. And this minimizes the resistive work of breathing, but you can see that there's a trade-off, that high lung volume breathing increases the static work of breathing. But in order to maintain gas flow, it is to the patient's benefit to minimize airways resistance, especially during expiration. And if the respiratory system becomes too great, the ability of the lungs to completely empty with expiration becomes impaired. And as we saw in Chapter 5 in the physiology of extubation failure, that as you have these prolonged pulmonary time constants with high airways resistance, then you're unable to completely exhale when your respiratory rate goes way up, and this can lead to dynamic hyperinflation, which can ultimately have actually very profound cardiovascular effects. Dynamic hyperinflation impairs diaphragmatic contraction. It increases the impedance of the pulmonary arterial tree, primarily or almost entirely by increasing pulmonary vascular resistance, because as we saw in a number of chapters, as your lung volume increases above functional residual capacity, that is, as your transpulmonary pressure, and again, transpulmonary pressure is the pressure gradient that determines lung volume. It's your alveolar pressure less your pleural pressure. As that gradient increases, lung volume increases, and you tend to collapse the alveolar population of pulmonary blood vessels. So when the transpulmonary pressure supersedes the transmural pressure of the pulmonary vessel of interest, then you get collapse of the vessels and pulmonary vascular resistance is increased. Dynamic hyperinflation is accompanied by the formation of autopeep, or autopositive end expiratory pressure, and this is by the name, it's an amount of end expiratory pressure that is positive, that is above atmospheric pressure, whereas at the end of expiration, your alveolar pressure should be atmospheric pressure, that is 0. But with the dynamic hyperinflation, you get air trapping, and this generates this end expiratory pressure that must be overcome in order to drive airflow on the following inspiration, so that is sometimes referred to as a threshold load that must be overcome before airflow can be generated on inspiration. And autopeep is the presence, what I just said, just prior to inspiration, and that's the threshold load. In addition to dynamic hyperinflation, there are large swings in intrathoracic pressure that are developed. In asthma, they have been found to range between negative 20 to negative 40 centimeters of water, that is 20 to 40 centimeters of water below atmospheric pressure, to up to 7 to 10 during forced expiration. Emphysema, it's been quoted from 20 below to positive 20 on expiration. I think even some studies have quoted inspiratory efforts can drop down to 60 below atmospheric pressure. So there can be very, very pronounced changes in intrathoracic pressure. So just breaking down obstructive lung disease into the effects on the cardiocirculatory system, and sort of flowing from the outline provided in Chapter 3, you can have volume effects and pressure effects, and it's sort of like the Venn diagram we talked about in Chapter 3. And primarily the lung volume effects that the lung volume effect that has the greatest impact on the cardiovascular system is dynamic hyperinflation. And so then you can sort of think of the volume effects as affecting the two main aspects of the Gaytan analysis, and that is firstly venous return. And as we saw in Chapter 3, and I kind of talk about the waterbed analogy, that as the volume of the thorax is increased, it decreases the volume of the abdomen and therefore increases the intra-abdominal pressure. And this tends to decrease the capacitance vessels of the abdomen and therefore increase the pressure head driving venous return back to the right heart. So that tends to favor venous return, but also you can have an increase in the resistance to systemic venous return, and that is as the abdomen is pressurized, then you tend to collapse the abdominal vessels, and this will increase the resistance to venous return. As you can imagine, and as I describe in Chapter 3, that which phenomenon takes precedence here, increased venous return by increasing the pressure head versus increasing the resistance of venous return, depends on the underlying volume status of the patient. Hypervolemic, you tend to have an increase in this mean systemic pressure and increased venous return, whereas the hypovolemic patient, the increased venous resistance effects tend to supersede and drive the physiology. And there are variable effects on pulmonary venous return as the lung volume increases. And I think I talk a little bit about this in Chapter 3 as well. As the lung volume increases above functional residual capacity, there tends to be there is a decrease in the capacitance of the pulmonary vasculature. And as lung volume increases, there tends to be a more pronounced increase in pulmonary venous return with inspiration, and that's because as the capacitance vessels in the pulmonary vasculature is decreased, it's a bit similar to the abdomen in that the pressure head driving blood to the left heart is increased as the capacitance of the pulmonary beds is decreased. And then in terms of how the dynamic hyperinflation affects cardiac function, while certainly it increases right ventricular afterload as a function of increased pulmonary vascular resistance from collapse and compression of the pulmonary arterial tree, it can result, and that can result in and of itself in tricuspid incompetence, which will, again, all of these effects here are tending to bend the cardiac function curve down and to the right. There can be LV diastolic compression or LV compression resulting in kind of an LV diastolic incompetence. But again, these in animal models at least, this diastolic effect doesn't really occur unless you have fairly large lung volumes or hyperinflation, and typically that's modeled in terms of the lung volume equivalent of a PEEP of about 15 centimeters of water or so. And then in terms of the intrathoracic pressure swings that you get in obstructive lung disease that we just talked about in the last slide, in terms of very low inspiratory pressures and very high expiratory pressures, this too affects venous return in that there can be an impaired maximal venous return, and this is essentially an Autopeep effect that you can see, and the physiology is essentially just the same as the application of extrinsic PEEP, and that the venous return curve is shifted rightwards, and the Starling resistor physiology that is generated, or the vascular waterfall physiology that is generated, results in a lowering of the maximum amount of blood that can return to the right heart, and that is from collapse of the great vessels. There's variation in inspiratory and expiratory filling pressures, and this will certainly affect venous return on inspiration versus expiration. And then there's variable effects on pulmonary venous return, and this is in terms of analyzing simply the pressure effects. This depends largely on variation in right heart output, because the right ventricle and left ventricle function in series as well as in parallel. In terms of cardiac function, there can be left ventricular diastolic incompetence via ventricular interdependence. So pleural pressure is lowered on inspiration. You tend to facilitate filling of the right heart, and filling of the right heart will result in acute LV diastolic dysfunction. Certainly on inspiration, the very low intrathoracic pressure will increase the transmural wall stress of the left ventricle and intrathoracic aorta during systole, and what that tends to do is increase your end systolic volume and decrease your stroke volume, so it impairs left ventricular output. And we'll summate all of the effects in that last slide in terms of the marriage of the Campbell and Gaytan analysis that I put forth in the latter aspect of Chapter 2, and we use that as the basis for discussion of heart-lung interactions in health in Chapter 3. And just to remember this slide, again, this is the Campbell analysis from Chapter 1, this is the Gaytan analysis from Chapter 2, and then the juxtaposition of the two that is described in much more detail in Chapter 3. We're going to do this in terms of disease state. So we're going to put the Campbell analysis on the z-axis going into the page, and then because they share pressure on the x-axis, we can join them here. And really the point that tethers these two analyses is the x-intercept of the cardiac function curve, at least in terms of how changes in intrathoracic pressure affect changes in the ventricular loading conditions. So as intrathoracic pressure changes, this x-intercept will shift along with changes in intrathoracic pressure, and then changes in volume tend to result in changes in the cardiac function curve and venous return curve from various different physiologies that we will certainly get into in this chapter. So let's talk about dynamic hyperinflation in the Campbell analysis. So again, this is a review from Chapter 1. This is functional residual capacity, this point here. This is the intrathoracic pressure at end expiration at your functional residual capacity, and it's determined by the intercept of the chest wall elastance curve at rest. That is, this is the curve that describes the pressure-volume relationship of the chest wall when there is no activity of the muscles of respiration. And this curve here is the pulmonary elastance curve, which describes the pressure-volume relationship of the lung. And again, elastance and compliance are simply mathematical inverses of each other, so I often use them interchangeably, but a low compliance is a high elastance, so that's stiff, whereas a high compliance is a low elastance, and that's kind of pliable. And again, these elastance curves describe the pressure-volume relationship just in terms of pressure and volume. That is it. It says nothing about gas flow. Whereas these curves here pertain to inspiratory gas flow and expiratory gas flow in terms of the additional amount of pressure that must be generated. So when you inspire, you kind of follow this dynamic curve, and your inspiratory pressure, your intrathoracic pressure along the x-axis here drops as gas flow proceeds and lung volume increases until you get to end expiration here at a higher lung volume. And again, this is pressure on the x-axis. In all of my slides, all of my lectures, the y-axis is the zero intercept, and here on the x-axis this is pressure, so everything here is subatmospheric and everything to this side of the y-axis is above atmospheric pressure. So again, what's really happening during inspiration and expiration, which I just showed you, is the chest wall elastance curve is not just sitting here passively, although I don't animate this in my lectures because that would just become, I think, a little bit too busy and frankly very, very time consuming. What's really happening during inspiration is the chest wall elastance curve is shifting leftwards. And again, I think I've shown this animation in a few different lectures now too, and I've stated this a few times before, but just to reiterate, the chest wall elastance curve when you inspire doesn't maintain this S-shaped figure. The S-shaped figure pertains to its resting state. During inspiration, it actually tends to create more of a comma-shaped figure, but I'm not illustrating that here. And then during expiration, you follow the passive curve and you return to functional residual capacity. So that's a normal tidal inspiratory effort. So if you throw this patient into an exacerbation of obstructive airway, so this could be like the beginning of an asthma exacerbation here, the airways resistance, inspiratory airways resistance curve increases. So again, the area under this curve here is the work of breathing for inspiratory airways, for dynamic, inspiratory dynamic work of breathing. And then the area under this curve here is the work of breathing for dynamic expiratory work. And sometimes I get my rights and my lefts mixed up, and I'll call this left. And that's not because I'm directionally challenged, although maybe it is, but it's just because I'm so used to looking at chest x-rays, and this is the left lung and this is the right lung. But clearly this is the right, we're looking at this is the right side of the graph, and this is the left side of the graph. So the left curve here is inspiratory resistance, and the right curve here is expiratory resistance. So you breathe in and you breathe out, and you get back to FRC, and you can see that the change in intrathoracic pressure is much more pronounced here, much more negative on inspiration, much more positive on expiration. But with time, as mentioned, the patient begins to breathe at high lung volumes, and this is to minimize airways resistance as airways are tethered open. And you can also note here that your functional residual capacity now becomes dynamically determined, and so as the lungs kind of gas trap and increase in volume, they begin to push out against the chest wall, and so then the pressure volume relationship of FRC begins to sort of climb up the chest wall elastance curve as the lungs are expanding and pushing out against the chest wall. So this becomes your functional residual capacity point here, and you can imagine that if your chest wall compliance was very poor, big ascites, obesity, chest wall edema, and whatnot, and this, as we'll talk about in later sections of this chapter, as the chest wall elastance curve is shifted down and to the right, that as FRC is dynamically increased during dynamic airways or during dynamic hyperinflation, then the increase in pleural pressure would be much more pronounced. But in this patient with the normal pulmonary or normal chest wall elastance as depicted by this curve here, this becomes their functional residual capacity. And now when they try to inspire, they won't get any gas flow until they've generated a much lower intrathoracic pressure. So the normal patient at FRC here, they just have to generate negative 5 and below or 6 below atmospheric pressure, and they start to get gas flow. But this patient doesn't get any gas flow until, whatever this is down here, say negative 10 or 10 centimeters below atmospheric pressure. So they inspire and then expire to functional residual capacity, and you can see that there's still pretty great swings in intrathoracic pressure, but airways, the work of breathing due to airways resistance is much diminished here, even though the elastic work of breathing has increased, because as you can see at higher lung volumes, the elastance curve of the lung and the chest wall is changed such that the elastance is high or the compliance is low. So there's an additional amount of energy that's invested in static work of breathing at high lung volumes. And Autopeep increases the inspiratory threshold load. So Autopeep is that increased pressure that begins to form in the alveolus during dynamic hyperinflation. So remember, in a normal patient at a normally determined functional residual capacity, the intrathoracic pressure is slightly subatmospheric. But in this patient now, the intrathoracic pressure is starting to become increased, and this essentially reflects your alveolar pressure that must be generated to initiate gas flow yet again, and that's depicted by this pink dotted line here. And so this is your inspiratory threshold load. So this patient, you can imagine, in order to, before they get any gas flow at all, they have to overcome all of this this pressure load here, this end expiratory pressure load, before any flow can enter the alveolus. And that's depicted like that. So that was dynamic hyperinflation on the Campbell analysis. And so now we're going to drop that down into the z-axis, as we've talked about in terms of this graphical marriage of heart-lung interaction. And again, pleural pressure on the x-axis here. This is zero pressure. This is below atmospheric pressure. This is above atmospheric pressure. This is in centimeters of water here. This is functional residual capacity. This is the lung elastance curve. This is the chest wall elastance curve. And then this is your inspiratory dynamic curve. And then this is your expiratory dynamic resistance curve. And the patient breathes in, and then they expire, and intrathoracic pressure goes way down, and then intrathoracic pressure goes way up. And then they return to functional residual capacity, say. So this is the onset of an exacerbation of obstructive airways disease. And as we talked about, there's an inspiratory drop in right atrial pressure, and that is because, as I've said this a number of times before, it's because this point here is key for the pressure interaction between the pleural pressure and the right atrial and right ventricular loading pressures. And that is at the cardiac function curve describes how much forward flow that you get. In this situation, it's the right ventricular cardiac function curve, but it describes how much forward flow you get on the y-axis here for a given intraluminal right atrial pressure. Okay, so if you were to bring blood flow to zero, so you'd essentially arrest the right ventricle, and again, because we're only looking at the cardiac function curve, you'd have to uncouple venous return to really do this experiment. So you'd clamp the SVC, clamp the IVC, and then measure the right atrial pressure with cardiac function arrested. Well, then the right atrial pressure would assume intrathoracic pressure, and that's why you can couple the Campbell and Gaytan analysis here, and it's really through this point. Okay, I hope that makes sense. When you inspire, therefore, the right atrial pressure will drop along with the drop in intrathoracic pressure. Now, what does that do? So take a look at this again. Remember that the Gaytan analysis, blood flow on the y-axis, it records the relationship of cardiac function and venous return, and this then becomes the operating point of your right ventricle, and that is, this is the right atrial pressure, your central venous pressure, your right ventricular end diastolic pressure. They're all essentially equivalent, barring any caval atrial anatomic abnormalities or tricuspid abnormalities. That becomes the filling pressure of your right heart, and that's measured here. It's above atmospheric pressure. And remember, when you put in a triple lumen, or you're measuring a CVP or whatnot off of a triple lumen or a pulmonary artery catheter, or what have it, you always reference it to zero, and this is the 0 point here. So the pressure that you're reading is really from here to here. Okay, so again, I've said this before, you're ignorant to the intrathoracic pressure. The distending pressure of the right atrium or the right ventricle end diastole is the pressure inside the cardiac chamber less the pressure outside. And we don't know what this is. We don't know what intrathoracic pressure is unless we're measuring it or estimating it from an esophageal pressure balloon. We don't know what your pleural pressure is. So we're ignorant to this point. And this is why we try and measure things at end expiration, because at end expiration, you're as close to atmospheric pressure as you can get, and therefore you get a better sense of what the true transmural or distending pressure is. Okay, so when you inspire, you've dropped your intrathoracic pressure really to a great degree, and you don't know what this is. All you know is what this is, and that's the reading you're getting off of your CVP. And in this patient, it's actually negative. And if you've been in an ICU long enough, you're going to see patients when the reading of on the CVP monitor is negative, even when you've zeroed it and you're doing everything correct. And it just does. How does that make sense? How is there a negative pressure in a cardiac chamber? Well, it is negative relative to atmosphere here, but the stress that the right atrium and right ventricle are feeling is actually much greater, and that's because we don't know what the intrathoracic pressure is. It's actually very low compared to the intraluminal pressure. So the distending pressure, which tends to tell you what volume the right atrium and right ventricle is taking on, is quite is quite increased compared to at the beginning of inspiration. And again, I think I've said this in previous lectures, but if this, say, hypothetically is 5 below, and this is 20 below, well, then the distending pressure here that the right heart is feeling is 15. Okay, and that would be exactly equivalent to opening the chest to atmosphere and then filling the right atrium and right ventricle with 15 millimeters of mercury of blood. It's the same stress that the heart is feeling, even though the measurement between those two scenarios would be different. So that's what happens to the cardiac function curves. It shifts leftwards, but also what you can see is that the slope of the curve has changed. So why does the slope of the curve change? Well, when you inspire, lung volume increases. And in patients with COPD, emphysema, the lung volume can increase to a great degree. And that afterloads the right ventricle, so the curve shifts down into the right. And that's because pulmonary vascular resistance goes up as lung volume is increasing. Also, you're tending to distend the right ventricle, and that increases the radius of curvature of the right ventricle, which increases the wall tension as a surrogate for your right ventricular afterload. That also tends to shift the curve down and to the right. Simultaneously, venous return is changing. As you can see, this is the initial state, and venous return has shifted here. And again, as I talked about in Chapter 3, when lung volume increases, the splanchnic capacitance beds, the venous capacitance beds in the abdomen are compressed, and that tends to recruit blood volume from the unstressed into the stressed volume, and therefore increase your mean systemic pressure, which would tend to facilitate venous return. But depending on the patient's baseline volume status, there may or may not be an increase in the resistance to venous return. And in this particular example, I have illustrated an increase in the resistance to venous return. You can see the slope has decreased. If this patient, say, had cor pulmonale and their abdominal venous beds were just engorged with blood, and they had lower extremity edema, and they increased their lung volume, well, they may increase their mean systemic pressure and not change the resistance to venous return at all, because the bulk of their abdominal venous beds are in the so-called West Zone 3 physiology. So as the capacitance beds are squished during inspiration, you may actually get facilitation of IVC flow and actually tend to preload the heart even more. So again, this is highly dependent on volume status. As I mentioned, the increase in lung volume tends to afterload the right ventricle. Then with forced expiration, kind of just the opposite occurs. You can see that now we've gone from an intrathoracic pressure that's quite below atmospheric pressure to an intrathoracic pressure that's quite high. And again, this is a function of the increased airways resistance on expiration. So this patient is bearing down to force out that breath. And now intrathoracic pressure has increased to a great degree, and the x-intercept of the cardiac function curve follows suit. The slope of the cardiac function curve tends to reverse because as the lung volume is decreased, the afterload is decreased on the right ventricle. As the volume of the right ventricle is decreased from the diminished venous return, the radius of curvature is diminished of the right heart, and that tends to decrease the afterload. There may be less tricuspid incompetence during expiration, and so that tends to improve the cardiac function curve as well. And again, what's the result here? Well, your measured right atrial pressure might be very high, but the true distending pressure of your right heart might be very diminished. And again, that's because the pressure around the right heart is also very high. So again, if this measured pressure were, say, 20, but your intrathoracic pressure were 15, well, then your distending pressure is only actually 5, and that's the same physiology as if you were to open the chest and fill the right heart to 5 millimeters of mercury. That the distending pressure would be exactly the same. So it's interesting that on inspiration, even though the measure pressure, as we saw, was very low, compared to on expiration, the very high measured pressure, actually on inspiration, the distending pressure of the right heart was much greater. And here I've depicted the venous return curve has shifted because in these patients, the resistance of venous return can actually increase on expiration as well. And that can occur if the patient predominantly uses abdominal muscles to grunt and bear down and force out that expired breath. And it will be particularly pronounced if the patient is more on the hypovolemic side and you compress those intra-abdominal capacitance vessels. So that's a lot of the effects, or some of the potential effects that can be seen with the cardiovascular system in response to changes in intrathoracic pressure during an exacerbation of emphysema, at least on the right ventricle. And one of the things that I want to point out, and this has clinical applicability, and I discuss more of it in Chapter 8, is that you can see that during if you remember, again, the forward flow or the output of the right ventricle is on the y-axis. So if you remember the patient's cardiac output or right ventricular output at the initial state was about here, and then during inspiration it dropped a little bit, and then during expiration it's dropped even more. And so this output, this forward flow from the right ventricle is actually varying to a great degree, and it's being driven by changes in intrathoracic pressure, not just changes in preload of the right ventricle, but also changes in afterload, changes in venous return, and that these changes in output that can occur as a result of wide fluctuations in intrathoracic pressure can lead to, down a few beats later, variations in left ventricular output, and therefore you get stroke volume variation and pulse pressure variation. And so these are very pertinent in terms of these new dynamic monitors that look at beat-to-beat changes in left ventricular output, and that these changes may or may not reflect preload responsiveness, especially in these patients that have very pronounced inspiratory and expiratory efforts. So it can lead to false positives in these pulse pressure variation and stroke volume variation monitors. The other important thing about the right ventricle is that the changes in intrathoracic pressure tends to have a more profound impact on right ventricular output than it does on the left ventricle, and that's because very small changes in intrathoracic pressure can result in very significant changes in venous return to the right heart, because the entirety of your venous return, which in the steady state is equal to your forward flow, your cardiac output, the gradient for that is only on the order of 5 to 10 millimeters of mercury. So just small changes in intrathoracic pressure can result in very large changes in right heart filling and right heart output. So now we're going to look at the exact same physiology, but we're going to look at it sort of from the perspective of the left ventricle. So again, functional residual capacity, where the arrow is here, the Campbell diagram is on the z-axis into the page, but now we have left atrial transmural pressure. And this curve is pulmonary venous return, not systemic venous return, and this curve is the left ventricular cardiac function curve. An important thing that I point out in Chapter 3 as well as here is that the drop or increase in intrathoracic pressure is directly transmitted to both the pulmonary veins and the left atrium and left ventricle. So although I am not, be very clear about this, although I am not animating this, when intrathoracic pressure drops, say during inspiration here to the left, what is actually happening is the pulmonary venous return curve and the left ventricular cardiac function curve are shifting leftwards in tandem. So you will measure a drop or a decrease in your left atrial filling pressure, but they are moving in tandem. So the transmural pressure between, or the transmural pressure does not change as a function of changes in intrathoracic pressure. And again, that's because pulmonary venous return, or the pulmonary veins in the left ventricle, are both exposed to intrathoracic pressure, and that's quite distinct from the right ventricle because systemic venous return, the systemic veins are exposed to atmospheric pressure, whereas the right heart is exposed to intrathoracic pressure, but it's quite different in the left heart. I'm not illustrating that because I think it would just become too busy, and frankly it would become very, very difficult to animate, but we have to be very clear about what's happening during inspiration and expiration during changes in intrathoracic pressure in the left heart, that these are actually would shift leftwards and then rightwards, but both of them in tandem. That's not to say that these curves cannot shift relative to each other, and I'm going to talk a little bit about that in these next couple clicks. So the large drop in intrathoracic pressure, again, this is the ghost of the right ventricle shifting leftwards relative to systemic venous return. Well, what does that do to the left ventricle? Well, I've depicted it here as bending the left ventricular cardiac function curve down into the right relative to pulmonary venous return. And that would tend to increase your left atrial filling pressure. Well, why does that occur? Well, there's a number of different mechanisms, and some of them are contentious, and some of them are well described in animal models and not so well described in human models, but it's probably a function of a few different things. And they will, the relative contributions of each of these mechanisms will certainly vary by the patient's volume status and disease state. But the first mechanism why you get a bit of an LV diastolic incompetence is ventricular interdependence. And as you increase the volume of the right atrium and right ventricle during inspiration, as we saw in the previous slide, well, as you volume load one chamber of the heart, you get an acute diastolic incompetence of the other side of the heart, and you can actually see this on echo where the left ventricle compliance can become impaired. We don't really see that on echo, but there's actually been some really neat studies, even relatively recently, that have looked at this in terms of patients with mild pulmonary hypertension, that even these patients with very mild pulmonary hypertension can have abnormalities in left ventricular compliance as a result of ventricular interdependence. And certainly, as we saw in Chapter 3 in variability in the Mueller maneuver, that the increase in transmural pressure of the right heart, and therefore right heart volume, will vary as a function of right heart function and volume status. So in the patient with a very poor right heart, whose volume overloaded with a high right atrial pressure to begin with, when they inspire, they're going to have a much greater increase in their right ventricular end diastolic transmural pressure, and therefore there'll be more of a diastolic effect on the left heart. And again, as I talked about in Chapter 3, that diastolic interaction is a function not only of the distending pressure of the right heart, but also as the relative elastances or the relative compliances of the ventricular free walls to the ventricular septum. So if the septum is poorly compliant, there'll be less of a diastolic interdependence effect, whereas if the free walls are poorly compliant, then there'll be more of a diastolic interdependence effect. So ventricular interdependence is one of the mechanisms, and the other is potentially a heart-lung interaction. That is, as the lower lobes gas trap and as the volume of the lower lobes is increased, you can compress the free wall of the left ventricle, which tends to suggest a diminished left ventricular compliance. And this is probably only starts to occur when you're at fairly high lung volumes in the lower lobes. But you can imagine that during a spontaneous inspiration, that the left ventricle is kind of pancaked, that the septum is being pushed into the left ventricle as a result of a bolus to the right heart, and then the lungs are pushing against the free wall of the left ventricle, and it's instead of going from this nice circular shape, like if you were doing a parasternal short axis view, for instance, it's going from this nice circle shape, it kind of goes to this pancake shape as it's being compressed between the septum and the free wall. And what this may actually do is this may tend to increase the stretch on the anterior wall of the left ventricle and on the posterior wall of the left ventricle. And if you've got some relative anterior wall ischemia, say some left anterior descending disease, and you start to stress the myocytes there, you may actually worsen left heart function as a result of this abnormal left ventricular geometry that you're creating. So this tends to increase left ventricular filling pressure and reduce cardiac output. And as I mentioned, it may disproportionately strain the LV anterior wall. Importantly, inspiration tends to shift the pulmonary venous return curve rightwards relative to the left ventricular cardiac function curve. And again, this is highly dependent upon the patient, the lung volume status. If the lung is boggy and full of West Zone 3, well, then you may shift this curve much more to the right and actually bolus the left heart to a much greater extent. In this patient with this exacerbation of emphysema, I've sort of assumed that maybe they've had a URI for a few days and they haven't been taking in PO, and so this patient might be on the hypovolemic side, so there might be decrease or little change in pulmonary venous return. But if the lungs are boggy and you're getting this bolus of blood to the left heart, then you can actually really strain the anterior wall by the physiology that I just described. And then on expiration, again, the ghost of the right heart we saw shifts to the right like this. You decrease right ventricular volume. You also tend to lower afterload as you increase intrathoracic pressure. And as lung volume decreases, you'd have less of a compressive effect on the left ventricle, and therefore you may regain a normal-ish left ventricular cardiac function curve, so you might actually have improved output of the left ventricle from inspiration, high afterload, and with diastolic effects from the heart and the lungs, and then on expiration you may actually facilitate output. So that was during inspiration and expiration, spontaneous ventilation. Now I'm going to get into this idea of pulmonary time constants and how it applies to the generation of Autopeep. So because of high airways resistance and high pulmonary compliance, the time constants of the lungs are prolonged. Remember, the time constant is a unit of the lung, a lobe. It can be whatever you want it to be, a lobe, an alveolus, a secondary pulmonary lobule. If there's high resistance and high compliance, the time constant is the resistance multiplied by the compliance, and therefore the time it takes for this viscoelastic object to return to its baseline status is prolonged. And that's essentially what I've just talked about. So high resistance, high compliance will result in a long time for this portion of the lung to return to its pre-deformation state. So with increased airways resistance, pulmonary time constants are prolonged. And while high lung volume breathing decreases the compliance and therefore time constants, the resistance is typically too great and the lung units do not fully empty on expiration. And this results in air trapping, and it tends to occur most commonly and most easily in the lower lobes. And this tends to compress the cardiac fossa and therefore elevate the juxtacardiac pleural pressure, which is the pleural pressure just around the pericardium. And what this can do is it can shift the cardiac function curve rightwards with respect to at least the right heart cardiac function curve rightwards with respect to venous return, and can lead to a drop in cardiac output. And this is very similar to the physiology of PEEP that I talk about in the chapter at the end of chapter 3. So what does Autopeep look like in this marriage of the Campbell and Gaytan analysis? Well, that's functional residual capacity, that's inspiration, that's expiration, and this occurs over and over and over and over again, and then the patient begins to move up the chest wall elastance curve like we talked about at the beginning of this section, and they breathe at a higher volume, and FRC is dynamically determined. And this has a number of effects on the cardiovascular system. Firstly, the right heart is shifted rightwards, and that follows the change in intrathoracic pressure. Now remember, at FRC, the x-intercept of the right heart function curve intersects at a slightly subatmospheric pressure, whatever FRC is. But then as air trapping progresses and FRC becomes dynamically determined and the lungs expand and push out against the chest wall, you start to increase intrathoracic pressure, and therefore this right atrial pressure and the cardiac function curve will shift rightwards with respect to the venous return curve. So you'll see that here. Additionally, take a look at the venous return curve. So this is at baseline. The venous return curve shifts rightwards somewhat, but also the P crit, or the pressure where you get collapse of the great veins as they enter the thorax, is also increased. So here, the P crit is at atmospheric pressure at 0, and that's because when the pressure in the IVC drops below atmospheric pressure, that tends to mimic or tends to follow the IVC dropping below abdominal pressure, and you get collapse of the IVC, and then you get this maximal flow, a maximal venous return. But with the application of PEEP, as the or not really the application of PEEP, but as the generation of Autopeep and the lungs increase in volume and compress the abdomen, this collapse occurs much more readily at a much higher pressure, and the degree of the maximal amount of venous return is diminished. So the result's a steady state decrease in right heart filling, so you can see the transmural pressure has decreased, and cardiac output, or at least the maximal amount of cardiac output, has also decreased. And note that at PEEP and Autopeep levels below about 15 centimeters of water, there's no real change in the diastolic properties of the heart. And I think I talked a little bit about that already. So now with an inspiration, you drop intrathoracic pressure to a great degree, and you may measure a very low CVP, and you can sort of imagine as the right atrial pressure is dropping relative to the pressure in the systemic veins, that this IVC is just collapsing away. And so no matter how low the intrathoracic pressure goes, no matter how hard you suck in, these great veins are just collapsing and preventing any augmentation of venous return, and that's this vascular waterfall physiology that you're seeing. So you may be measuring a very low CVP, but because of the physiology of this vascular waterfall, you're actually not really increasing the distending pressure of the right heart to a great degree. And then on expiration, similarly, from physiology, like we've discussed in previous slides, you're increasing your intrathoracic pressure. You're going to increase your measured central venous pressure or right atrial pressure, but because the intrathoracic pressure is so high, the distending pressure of the right heart might be actually quite small, and you may have quite a diminished cardiac output. Remember, the forward cardiac output or flow is on the y-axis here, so it's much decreased. And similarly, for the left heart, again, we're just going through this Autopeep physiology as the patient inspires and expires, and they begin to air trap and dynamically hyperinflate. Now the right heart is shifted, the right ventricular cardiac function curve is shifted rightward with the increase in intrathoracic pressure, and that can have some improvement in the LV diastolic function if the right heart is quite full, and you're having diastolic interdependence effects. But assuming there is none in this example, intrathoracic pressure increases. Inspiration, the drop in intrathoracic pressure, tends to increase left ventricular afterload. There tends to be compression of the LV by interdependence effects. And as we talked about, there can be compression of the LV free wall, which may impair LV diastolic function if it's at quite high lung volume. So the left ventricular cardiac function curve is shifted down and to the right. And again, depending on the volume status, the quote-unquote volume status of the lungs, there may or may not be an augmentation of pulmonary venous return. Then during expiration, intrathoracic pressure increases. The ghost of the right ventricular cardiac function curve shifts rightwards. the right ventricular volume shrinks, therefore some stress is taken off of the LV. The increase in intrathoracic pressure tends to unload the LV, so you can shift your left ventricular cardiac function curve up and to the left, and you may actually have an augmentation of cardiac output. Okay. But then that was sort of the initiation of Autopeep. As Autopeep begins to develop, and really after only a few cardiac cycles after the initiation of Autopeep, the pulmonary venous return curve is going to shift leftwards relative to its baseline state, and that's because there's been an overall decrease in right heart output. So pulmonary venous return is shifted. So now when you inspire, there will be an increase in pulmonary venous return on account of the increase in lung volume, which tends to squeeze blood out of the lungs towards the left ventricle, but you'll favor falling on this depressed LV cardiac function curve on account of the increase in left ventricular afterload and the diastolic compressive effects of the right heart and potentially the lungs compressing the free wall. And then when you expire, you'll favor an improved cardiac function curve because afterload of the LV is mitigated during spontaneous expiration, and also because right heart volume may be decreasing. But while you're favoring an improved LV function curve during expiration as lung volume is being diminished, you'll tend to have a diminished pulmonary venous return curve. So again, the effects on LV output during inspiration and expiration can be variable and will depend on the underlying volume status of the patient, particularly in terms of pulmonary venous return, the west zone physiology of the lungs. So that was spontaneous inspiration in an exacerbation of obstructive airways disease. Now I'd like to switch gears, well, not really switch gears, but talk about the physiology of mechanical ventilation and emphysema. So during mechanical ventilation, if the exhalation time is reduced, for example, because of a high tidal volume or respiratory rate, the risk of air trapping and autopeep, as we've just talked about, can become quite great. In spontaneously breathing patients, the effects of autopeep may be mitigated by inspiration, as the low intrathoracic pressure during inspiration could augment venous flow, but in the passive mechanically ventilated patients, the effects of autopeep can be catastrophic because cardiovascular collapse will ensue as there's no drop in intrathoracic pressure that can tend to augment venous flow or venous return and offset some of the untoward effects of autopeep. So returning to my modified Campbell analysis, again, this is the lung elastance curve. This is the chest wall elastance curve. This is pressure on the x-axis in centimeters of water and volume in the y-axis. And I've labeled this pleural pressure or airway pressure because this curve here is actually represents airway pressure. And it's essentially a function of airway pressure and thoracic volume as it pertains to the elastance or compliance of the respiratory system. And so how is this derived? Well, I talk about it quite a bit in Chapter 1 and then in Chapter 3 as well. But let's talk about it in terms of emphysema. So if we imagine an increase in pulmonary compliance without any change in chest wall compliance, which you tend to see in emphysema, the elastance curve of the lung is shifted up and to the right, FRC is increased, and now we can derive the compliance of the respiratory system by saying that at each volume here on the y-axis, the lateral distance between the lung elastance curve and the chest wall elastance curve, this lateral distance here in pressure, is the amount of pressure that the muscles of respiration must generate to achieve that volume. Or conversely, as I've depicted here, it's the amount of pressure that the ventilator must apply at the proximal trachea to achieve that volume. And again, this is in the passive or heavily sedated patient, so there's no active inspiration or expiration that occurring. So if you were to now graph these, the compliance of the respiratory system, again, respiratory system being the lungs and chest wall together, has increased. And so this, as I've talked about times before, is essentially a series of plateau pressures, that if you apply a pressure to achieve this volume, you apply a higher pressure to achieve this volume, a higher pressure to achieve this volume. Each of these is a plateau pressure that you would measure at the proximal trachea during an inspiratory hold maneuver. So the plateau pressure has decreased compared to that baseline condition, but the pleural pressure has not, because remember, the pleural pressure tends to follow the chest wall elastance curve. As the lung is increased in volume, it pushes out against the chest wall, and therefore the elastance of the chest wall will determine the pressure that is generated between the lung and the chest wall itself. So when there's an increase in thoracic compliance, but the compliance is due to the increase in compliance is due to increase in lung compliance out of proportion to the chest wall, more of the airway pressure will be transmitted to the pleural space, or a greater fraction of the airway pressure will be transmitted to the pleural space. With emphysema, there's a large increase in airways resistance, so the peak pressure, again, this is airway pressure here, will be much increased. So while peak pressures may be quite high in the obstructive patient, the amount of this peak pressure that's transmitted to the pleural space, that is the intrathoracic pressure, can be much, much less. Because the pleural pressure follows the chest wall compliance curve, anything that reduces chest wall compliance in these situations will result in an exaggeration increase in your pleural pressure. And the following animations will really assume the patient is completely passive, as I mentioned, or heavily sedated with or without paralysis. So if the patient is making inspiratory efforts while on mechanical ventilation, it's important to notice, I think a lot of people don't recognize this, is that intrathoracic pressure or pleural pressure can still be predominantly negative even in the patient who's being mechanically ventilated. So let's talk about mechanical ventilation in emphysema. So again, this is the modified Campbell analysis on the z-axis going into the page that I just talked about a couple slides ago. This is pleural pressure or airway pressure in centimeters of water. This is 0. This is above atmosphere. This is below atmosphere. This is the elastance curve of the respiratory system. That is the lungs and chest wall together. And it's a function, this curve here is a function of the distance between the elastance curve of the chest wall and the lungs together. And then this curve to the right of the pulmonary elastance, or of the respiratory system elastance curve, this represents airways resistance. And again, this is here, this would represent airway pressure that you're measuring off the ventilator. And that's quite different from the pleural pressure, which for the most part we're completely ignorant of. This is functional residual capacity at the beginning of an inspiration. If you were to apply extrinsic PEEP on the ventilator, or if the patient were to develop Autopeep, the pleural pressure increases along the chest wall elastance curve like this. So if that was Autopeep or extrinsic PEEP, you would increase your intrathoracic pressure by that degree. And then with a ventilator breath, the pleural pressure will increase, but not to the same extent as the peak airway pressure. So if you were to give a breath from there to there, it's very different. You can see the pleural pressure is increasing here from, say, atmospheric pressure to, a number of centimeters of water above atmospheric pressure. That's very different from the measured peak pressure, which you would measure to be quite high. And this is, again, what you would measure at the proximal trachea off the ventilator. Okay, so let's run through that with the Gaytan analysis superimposed. Again, blood flow on the y-axis, and now it's right atrial pressure in millimeters of mercury on the x-axis. This is the distending pressure, this is your measured CVP here, and this is your cardiac output. Okay, so now let's apply some extrinsic PEEP to the patient. So the cardiac function curve will shift rightwards along the along with the increase in intrathoracic pressure. The pressurization of the abdominal venous capacitance beds increases your mean systemic pressure. And again, this is partly due to pressurization of the abdominal capacitance beds, but also due to sympathetic discharge. And as you apply PEEP, There's actually an increase in sympathetic tone that tends to recruit unstressed volume into stressed volume, and therefore increase your mean systemic pressure. So even though your central venous pressure has increased from the baseline state, your distending pressure may have decreased a little bit. So, as I mentioned, this is altered systemic venous return. You've diminished your maximal venous return. You've increased the P crit, or the pressure at which the great vessels collapse, moving into the thorax from atmospheric pressure to above atmospheric pressure. Now, if this patient were completely sedated and not making any inspiratory efforts, an inspiratory breath would shift the cardiac function curve rightwards to the new intrathoracic pressure here. I haven't animated it here, but the breath would tend to increase your mean systemic pressure transiently with the positive pressure breath, and that would tend to defend some of the decrease in cardiac output that you'd see. So maybe the venous return curve might actually shift out here rightwards, and you'd bolus your right heart a little bit, so there'd be a, not as quite a pronounced decrease in your cardiac output. But your transmural pressure has shrunk, and your cardiac output has shrunk as well. Now you can see here that during this breath, this is the increase, that magical arrow that just came in and then disappeared. That would be the increase that you would, the pressure increase that you would measure at the proximal trachea. That would be a reflection of the peak pressure. Again, it's while the peak pressure may be quite increased in this patient with obstructive airways disease, and maybe you're reading a peak pressure of 50 or 60 and you're kind of freaking out. Well, I've drawn this to highlight that may not be the pressure that the right atrium and the right heart is seeing at all, because that's following the intrathoracic pressure, which is really dependent upon your lung volume and your chest wall compliance. Okay, so same thing now with the left ventricle. The application of extrinsic PEEP, or the development of Autopeep, increases intrathoracic pressure along the chest wall compliance curve. A breath on top of that will tend to increase intrathoracic pressure and airway pressure to that extent. Now running through that, now this is pulmonary venous return. This is left atrial pressure on the x-axis, and then the left atrial distending pressure as depicted by this little dumbbell. Pulmonary venous return, left ventricular cardiac function. You now increase PEEP. The ghost of the right heart shifts rightwards. Okay, and what's the effect on pulmonary venous return? Well, it depends on the volume status of the lung, as we've talked about already a number of times. If the lung is predominantly West Zone 3, well, then you may have an increase in venous return. If it's predominantly West Zone 1 and 2, you may increase the driving pressure for blood back to the left heart. But if there's a high degree of pulmonary venous collapse because of West Zone 1 and 2 physiology, you may actually tend to increase the global pulmonary venous return. You may diminish overall pulmonary venous return from the lungs during the application of PEEP. The ventilator breath, as I mentioned, alters the pulmonary venous return curve depending on the underlying volume status. With excessive extrinsic PEEP or air trapping, the pulmonary venous return will diminish, and the left heart may be compressed in the cardiac fossa. So you can see that with time, this is kind of your baseline state after the first couple of breaths from the after the initiation of mechanical ventilation. But with time, as the right heart forward flow, right heart output is diminished, your pulmonary venous return curve will shift leftwards as well, and that will tend to diminish your left heart output. So now with expiration, as you see here, your left ventricular cardiac function curve may shift up and to the left, and the reason that is because the reason that happens with expiration is your pulmonary venous return curve shifts leftwards, and that's because with expiration, lung volume is decreasing, so there tends to be less blood squeezed out of the lungs. And what I've illustrated here, I mean, it certainly can be contentious in terms of what the underlying physiology on the left ventricle would be. And in this cartoon, I'm trying to, because this is an exacerbation of emphysema, I'm trying to highlight the effects of right ventricular afterload and the compressive effects of the lungs on the LV cardiac function curve. And as I mentioned, with an inspiration during mechanical ventilation, you may afterload the RV if the pulmonary vascular resistance is quite high. And if you afterload the RV, you may, it's hard to, you could make an argument multiple ways, but you could say if the RV afterload is increased, you may distend the RV during inspiration, and therefore you would impair LV compliance during inspiration, and therefore that is relieved on expiration. So you may actually improve the LV cardiac function curve on expiration as the RV is unloaded during expiration. Similarly, during expiration, if lung volume is being reduced and the lung volume was really compressing against the LV and creating kind of a diastolic dysfunction, you may have that released during expiration. And then during inspiration, again, those effects will be reversed. You're going to bolus the lungs, or you're going to bolus the left heart as lung volume increases, so your pulmonary venous return curve will shift rightwards. And if the lungs expanded and compressed and impaired the diastolic capacitance of the lung during inspiration, if the lungs are at very high lung volume, then the LV cardiac function curve might shift down into the left. And similarly, if the right ventricular afterload is very high, that increasing lung volume above FRC will further afterload the right heart, which may distend the right heart and therefore cause an LV diastolic dysfunction, which again would shift the left ventricular cardiac function down into the right. So that's what I'm trying to animate here. Again, you could make the argument, well, maybe the positive pressure is unloading the LV during inspiration, but again, I'm trying to stay away from, I'm trying to make this as clean as possible, and that this is in a patient with exaggerated airways resistance, air trapping, high lung volumes, high right ventricular afterload. But they may have a normal left ventricular cardiac function curve, so the effects on LV afterload with positive pressure might be kind of mitigated in this patient. So that was mechanical ventilation and emphysema. As discussed in the previous chapter, an increase in the transpulmonary pressure tends to squeeze blood out of the lungs and increase pulmonary venous return. This shifts the pulmonary venous return curve rightwards. If the patient is passive, the preceding expiration, that is dropping intrathoracic pressure, should result in the greatest venous return to the right heart. The increased venous return during expiration should then be more readily transmitted during the subsequent inspiration. So this is kind of this piston-like effect of the lungs accepting blood during expiration and then squeezing blood forward to the left heart during inspiration, during mechanical ventilation. While positive intrathoracic pressure certainly facilitates left ventricular unloading, this is most prominent in patients who are volume overloaded with a poor EF. Whereas in patients with emphysema, and especially those with air trapping, a high baseline RV or residual volume to total lung capacity ratio, the effect of cardiac compression may supersede and result in this diastolic dysfunction. I'm just sort of backtracking over what I just tried to explain. And the diastolic dysfunction would be made worse with each cycle breath. If pulmonary venous return is facilitated with each breath, this may result in a high wedge pressure, a high filling pressure. And then it was predominantly emphysema that I was illustrating in those graphs, but versus asthma, it's common to distinguish emphysema from chronic bronchitis and asthma in terms of baseline lung hyperinflation, but there's actually quite a bit of clinical overlap, particularly in long-term untreated asthma, which may be the patients that you see in the intensive care unit. And in all cases, there's the possibility of dynamic hyperinflation, air trapping, and high RV afterload. And the stress on the RV will be determined by the patient's underlying volume status, intrathoracic pressure swings, and the shape of the right ventricular cardiac function curve. States of high systemic venous return e.g. core pulmonary, poor RV function, high RV afterload from very high pulmonary vascular resistance, and large negative swings in intrathoracic pressure will facilitate RV distension, strain, ischemia, and impaired LV function by parallel ventricular interdependence. So that was a whopper of a section. We talked, quite extensively of the effects of intrathoracic pressure and lung volume on right and left heart loading in both spontaneous ventilation and mechanical ventilation. And again, I want to re-emphasize that the physiologies that I just depicted is not what's occurring in every patient that you get in the intensive care unit. You have to think about each patient very carefully. You have to think about their cardiac function. You have to think about their volume status. You have to think about the fluctuations in intrathoracic pressure and how these are all affecting each other in turn. And you may have very different responses in patients with chronic bronchitis versus emphysema in terms of the degree of lung hyperinflation, in terms of the degree of ventricular interdependence, right ventricular afterload increases, changes in left ventricular diastolic function, changes in left ventricular afterload. But what I hope that those slides did was give you a lot to think about in terms of what potentially could be at play, and that you understand that in order to interpret a patient's hemodynamic parameters, you really have to have in mind what their underlying volume status is, what their right and left ventricular function is in terms of contractility, valvular function, afterload. All of these variables are at play here, and they can all come together and make this a very challenging clinical situation indeed. So that's it for emphysema and obstructive airways disease. The next section is going to be about systolic heart failure. Thanks very much.